everybody. Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Kimani Hendricks, and I'm joined by Dr. Ben Thrower. This is one of my favorite conferences and always a good way to end the year. We're doing some MS and holiday trivia. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at Shepherd Center. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. And presently, he is the senior medical advisor for the Multiple Sclerosis Foundation and often contributes to our quarterly magazine. So I'll just turn it over to you, Dr. Thrower. Get out of the way. I can't wait for the trivia.
Wonderful. Happy holidays, everyone. I thank you for joining us. I hope everyone had a wonderful 2022, and I hope you have an even better 2023. As Kamani said, this is one of our favorite things to do. We're going to have some fun with holiday trivia, but we're also going to learn some stuff about MS. We wanted to make this kind of especially fun for our holiday aficionados. So we're going to have trivia questions as we go through the program related to MS and to holiday stuff, mainly holiday movies and holiday traditions. So if you answer one of the holiday questions correctly, what I would like you to do, realize you're playing for this beautiful puffy jacket with a Shepherd logo on it. If you get one of the holiday questions correct, please email Kamani after the program. You should be able to find her email address in your registration and give her your name and address, and we will get this jacket mailed out to you. It is a medium. If you want to go ahead and put your size in your email, if you're comfortable doing so, I can probably switch it out for a different size if need be. It looks like it's probably running a little bit large for a medium. So with that, we will get started. And first up, we have a holiday trivia question. This is one of my favorite, I would say it's in my top 3 favorite Christmas movies. So in National Lampoon's Christmas Vacation, what did Aunt Bethany say instead of grace when she was asked to lead the prayer before dinner? So she was asked to say the blessing over dinner, and instead she substitutes something else. So you can raise your hand. Let's probably do raised hands, I think would be the best. If we don't get any raised hands for Kamani to call on, we'll go to a written in answer.
So the first hand I see raised is Tiffany. Can you unmute?
I think I unmuted.
Good.
All right, what do you got?
The Pledge of Allegiance.
You are absolutely correct. She said the Pledge of Allegiance. Good job.
Thank you.
Yeah, what such a good movie. All right, so it sounds like you're a pro at this. So what gift did she bring to the dinner?
Oh, crikey.
This was just for fun.
Fruitcake? No, I don't know what she brought.
She wrapped up her cat.
Oh,
yeah.
Yes.
The kitty
right.
had an unfortunate demise with the Christmas tree light.
Yes.
Good job. Yeah, so if you'll shoot your name and address to Kamani, that would be awesome.
Thank you.
My email address is in the chat, everybody. So if you get a question correct, please copy paste it and send it to me.
And we're only going to do the prize for the holiday questions. Yeah. Okay. Just to keep the pool narrowed down. And what will happen is when you email your name in, the folks staff at MS Focus will draw a name from a hat and we'll get it out to you. So an MS question. MAB and natalizumab, ocrelizumab, and alemtuzumab stands for A, monolithic audio bomb, B, monocytic antigen broth, C, monoclonal antibody, or D, mammalian autoimmune basophil.
The first hand I saw go up was Jude.
Jude.
Yes, that would be C, monoclonal antibody.
Absolutely correct. Good job. One of the things I'm always so impressed with the MS community is you guys you're a really sharp, well-informed group of people. When I speak to my neurology peers in other areas, maybe stroke and Parkinson's disease, not always the same thing. So you have hats off to everyone in the MS community for really being good self-advocates for yourselves and being knowledgeable. So monoclonal antibodies are engineered antibody. So normally when your immune system makes an immune response, it's a polyclonal response. Your immune system makes a lot of different antibodies to throw at whatever it's trying to attack. Monoclonal antibodies are one specific line of an antibody engineered in a lab to do one very specific thing. So almost any step in a disease process where we know the receptors that are involved in that step, we can now potentially make monoclonal antibodies to go after that. We also, you're hearing discussions in the COVID world about a monoclonal antibody called Evusheld. Evusheld, we recommend for some people who might be immunocompromised due to an MS therapy as potential COVID protection, because we know that some of those folks don't make good antibody responses on their own to vaccination, booster, or natural infections. Good job. So which of these drugs is FDA approved to help improve walking speed? Would that be A, baclofen, B, Acthar gel, C, Tysabri, or D, Ampyra?
I saw Jupe's hand go up.
What you got?
I think it's Ampyra.
You are correct. Good job. So, when we think about symptom management drugs, we have medications that manage just almost any symptom out there. So Ampyra is our one, or dalfampridine, the generic formulation, are FDA approved to improve walking speed. These are both a very, very similar molecule to 4-aminopyridine or 4-AP. 4-AP has been around forever. It's the non-FDA approved version of the drug. We never thought of 4-AP as just being a walking drug. We always thought of it as something that helped with any symptoms that were related to heat exposure or exertion. If your vision dimmed out when you got overheated, we would think maybe 4-aminopyridine can delay that the time until your vision gets dim with heat exposure. When you want to get FDA approval for a drug, though, you've got to be very specific about what you want to study. And so they couldn't study heat exposure or exertional symptoms. So they really had to focus in with dalfampridine or Ampyra into something specific. And that specific thing they focused on was walking. The Ampyra, dalfampridine, and 4-aminopyridine seem to work in about 40% of individuals who take them. We don't understand why that is, but typically if you were to start one of these medicines, give it about 4 weeks and you're going to know if you're in that 40% responder group or the 60% non-responder group. Good job. Next question. Which of these drugs is not like the other? So one of these is different in some way. So does Ocrevus stand out, Tysabri stand out, Rituxan stand out, Kesimpta stand out, or Truxima stand out? Which of those is the oddball?
Sherry raised her hand first, from what I could see.
Sherry, what you got?
Kesimpta,
Kesimpta. Why do you think Kesimpta would be different?
because it's an injection, and the others are infusions.
I'm gonna give you credit for that. I accept that answer. So that is correct. So I'm gonna give you a right for that one. Is there one that's different due to mechanism of action, though?
I've never heard of Truxima, so
Truxima.
might be that one.
So does anyone else out there have a hand up that has a thought on which of these drugs does not work in the immune system like the other ones do?
Jim has his hand up.
Hey, Doc, that'd be Tysabri. It's a immune system modulator versus what's the term where it changes?
More of an immune suppressant.
Suppressant, yes.
So that's correct as well. So Tysabri works differently than the other ones up there. So specifically, Ocrevus, Rituxan, Kesimpta, and Truxima are all B cell therapies. These are all anti-CD20 monoclonal antibodies. They're binding to the CD20 receptor on the surface of immature B cells and targeting those cells for elimination. So they do have a mild immunosuppressant effect. So everything except Tysabri is a B cell therapy. Tysabri is also a monoclonal antibody, but it has a very different mechanism of action. So it's working on the alpha integrin receptor of T cells. When those inflammatory cells want to cross the blood-brain barrier and get into the brain and cause harm, they have to use a receptor on their surface that binds with the receptor on the blood-brain barrier, kind of like a lock and key. Blood-brain barrier opens, inflammatory cell goes in. So what Tysabri or natalizumab is doing is it's not letting those inflammatory cells use their key to open the door. So yeah, you could, I think either Tysabri or Kesimpta could be right answers on that one. Good job, you guys. So a holiday question. So what is the name of the holiday that celebrates the visit of the Magi or the three wise men? Is it A, Boxing Day, B, All Saints Day, C, Epiphany, D, Good Friday, or E, Black Friday?
Diane has her hand raised.
Diane, what you got? You may be muted, Diane.
Can you unmute? I don't think she can.
Uh-oh.
I'll go to, wait a second. She's trying, it looks like. Oh, Diane, I don't want to pass you over.
I hate that
I know.
technology's not cooperating.
No, it's not. But I see Teresa has a hand up. Diane, swing back around if you know the next one, okay?
Teresa, what do you got? Uh-oh, we're having more muting issues.
You guys, if you want to utilize the Q&A or chat box as well, if you're having a difficult time unmuting, this is for everyone. Hopefully we don't continue to run into the problem, but if we do,
Really?
there are other ways to get your answer in. So Diane says C, Epiphany.
That is correct. Good job, Diane. So Epiphany, if you're a Christmas aficionado, so the 12 days of Christmas end with Epiphany, which is when the wise men or magi visited. I know in our household, I like leaving all my Christmas decorations up until Epiphany and then taking them down at that point. I may be in the minority. I know there are other folks who are like, nope, New Year's Day, they got to come down or it's bad luck. But I like the Epiphany tradition. Okay, while we're on the wise men, I'm gonna throw out one more, and I will preface this with saying, in the history of me asking this question, only one person has gotten it right. But if anyone knows the names of the three wise men, throw your hand up.
Don't see anybody yet.
Yeah, that's a tough one because it's not in the Bible. It's in another ancient text. So Balthazar, Melchior, and Gaspar. There's some great documentaries about the wise men out there too on YouTube if you're interested in looking at the sort of the astrological significance of what they were following and what it meant in ancient times. So yeah, cool stuff.
Wow.
All right, good job. Which of these drugs is not like the other? So which is the oddball or the odd man out based upon, and I'll say this one is based upon the mechanism of action of the drug. So would it be A, Gilenya, B, Ponvory, C, Vumerity, D, Zeposia, or E, Mayzent?
No hands yet.
No takers.
You're thinking.
And there's no penalty for wrong answers.
We got one.
All right, what do you got?
JW.
And are we unmuted?
Here we
He
go.
has-
I think I'm on.
You're on.
Vumerity.
Which one is out, Dodman?
Vumerity.
You are correct. So what makes that one different?
Well, let's see. Probably just the mechanism of action being what is it? Diroxyl fumarate?
Yep.
Something like that.
So you're absolutely correct. So everything on there except Vumerity is what we call an S1P receptor modulator. So all of these other pills, the Gilenya, Ponvory, Zeposia, and Mayzent, work to affect how lymphocytes are able to leave the lymph node. So when lymphocytes go into the lymph node as part of our lymphatic system, it's one of the ways that they're programmed and told what their job is in life. When they leave the lymph node, that's not a passive process. They actually have to be given permission to leave the lymph node. And what these S1P receptor modulators do is they block the ability for certain lymphocytes to leave the lymph node. They're not killing any cells. They're just locking them up and not letting them get out and cause inflammation. When we do blood work, when we do your CBC and you're on one of these S1P drugs, your total lymphocyte count is going to be low. We always tell people it's probably a good idea to let your primary care doctor know that you're on this MS drug that can do this, because if they're not familiar with that drug, they might panic a little bit. Those cells are still there in your body. They're just locked up. We can't measure them because they're not circulating in your bloodstream. But so if someone wasn't expecting that on your blood work, it could look a little bit frightening. Vumerity, as JW mentioned, is the odd man out. So this drug works through a pathway called NRF2 or NRF2. It's probably a little bit more of an antioxidant pathway. And so Vumerity is kind of the new and improved version, if you will, of Tecfidera or the other fumarate drug. So it's in that class. One of the advantages of Vumerity over its predecessor Tecfidera is a lower risk of GI side effects with Vumerity. Good job. So which of these is a type of primary MS fatigue? So it's a word we use for one of the more common types of fatigue in MS. Is it A, anhedonia, B, lassitude, C, altitude, or D, borborygmi?
Sherry raised her hand first.
Sherry,
B, lassitude.
B, lassitude. You are absolutely correct. So lassitude is one of the two primary types of MS fatigue, the other one being nerve fiber fatigue. So lassitude is the type of fatigue that you really don't have to do anything to have it. It's non-exertional, non-heat related, just this overwhelming sense of I can't do anything. I think so it was important to put A in there, anhedonia. Anhedonia sometimes can get a little bit mixed up and confused with lassitude. Anhedonia is a symptom of depression, and so it literally is a Greek term for a lack of hedonism. It means you don't want to do things that you would normally find fun. And it can translate to anything. It can mean going out to dinner, going to a movie, getting out of bed, having sex. It's just a lack of desire to do something. Sometimes, people with MS who have lassitude can't do something that would be fun because they're too tired to do it. Whereas with the anhedonia, the actual desire to do it is not even there. And there's nothing to say that a person with MS couldn't have both of these symptoms. Maybe sometimes it's more the anhedonia, and other times it's more the lassitude. So one of the goals in determining appropriate treatment paths is to kind of sort out, which is the person dealing with. And for extra credit, anyone want to tell me what borborygmi is? Got any takers out there?
Not yet.
So That is the medical term for the noise your stomach makes when it grumbles. So you can impress your friends and relatives at dinner now, and you know, or if they're hungry, and tell them, "Oh my gosh, that is some impressive borborygmi." There's your word for the day. All right, back to a holiday question. What was the dog's name and how the Grinch stole Christmas?
Oh, I hope.
Oh, no takers on that one?
Jude.
Jude, what do you got?
Max.
Yay, Max. Absolutely. Good job. Dude, you sound like a Christmas movie aficionado. Yep, that is right.
More of a dog aficionado.
Oh, hey, either
Christmas
way.
too.
Yep. So Max was the dog. Very good. Good job. So just for extra credit, Jude, or if you're up to it, or anyone else, what's this character's name?
Oh,
Cindy Lou.
So Cindy Lou Who, absolutely.
Cindy Lou Who, that's it. Oh,
Anyone want to guess how old she was in the cartoon? They never say in the movie, but in the cartoon version, how old was Cindy Lou Who?
I forgot.
He
Oh,
was
Jude, I think your hand is up again.
no, I don't know how old she is.
not more than 2. So everything in the movie went based on the book, the rhyme in the book. So Cindy Lou Who was not more than 2. Good job. What do we got here? Which drug has been shown to slow disability progression in primary progressive MS? Would that be A, ocrelizumab, B, placebozumab, D, daclizumab, or so that was C, or D, alemtuzumab? Which one is slows disability in primary progressive MS?
Jude had his hand up first.
It's A, ocrelizumab or ocrevus.
You guys are just too smart. That is correct. So that is our only FDA approved treatment option for primary progressive MS. Does that mean that's the only thing that we would potentially talk about? And we do sometimes look at things that are off label. So ocrelizumab, realize, is just the fully humanized version of an anti-CD20 monoclonal antibody. Rituximab, in both the Rituxan version and the Truxima version, are also anti-CD20 monoclonal antibodies. They're just not quite fully humanized. In theory, if ocrelizumab works, you would expect that these other 2 options with the same mechanism of action could work as well. Now, in fairness, there was a primary progressive study with rituximab many years ago, and it did not meet the endpoints. So, I mean, there is a negative study for rituximab, but a positive study for ocrelizumab. Similarly, with our, the old school Copaxone, that drug was studied in primary progressive MS, and overall the trial was negative. But if you looked at the people who had more rapid progression of symptoms with primary progressive MS, which tended to be more the men than the women, there was a statistically significant difference between the people who were on Copaxone versus on placebo. So there was a little smoking gun there saying there might be a treatment effect with those off-label options. Good job. Myelin is mainly made up of A, protein, B, carbohydrates, C, fine Corinthian leather, or D, fat.
I saw Karen's hand up go first.
Karen, what you got?
That.
Fat. You guys are just too smart. I don't think people have missed a single one. So that is correct. So we get a lot of people answering protein on this one. And protein is an important component of myelin, and it is probably what the immune attack is directed against. But 95% of myelin is actually fat. If you look at a fresh brain sample, the white matter in the brain is very shiny, almost gelatinous looking, and it's shiny because it's mostly fat. Fat is a really good electrical insulator, and that's myelin's job. It's an electrical insulator. It lets electrical information be conducted much more quickly and efficiently up and down the central nervous system. So that is absolutely correct. But we cannot leave this without talking a little bit about fine Corinthian leather. So fine Corinthian leather, how many people remember this guy, Ricardo Montalban, when he was advertising in the 1970s for the Chrysler Cordoba? And he used in his, really cool Spanish accent, he described these wonderful leather seats in the Cordoba as having fine Corinthian leather. Totally made up word. So he ad-libbed that on the spot. There is no such thing as fine Corinthian leather, but it sounded so cool when he said it that people totally bought into it, and everyone wanted to have a car with fine Corinthian leather seats. What do we got next here? Oh, this is a good one. And I would say if you are a fan of the movie The Christmas Carol, I vote that the Disney's version is the best one I've ever seen. I think Jim Carrey knocked it out of the park with this. So in the movie A Christmas Carol, how many ghosts appear to Scrooge?
I saw Jim's hand go up first.
Jim,
I'm
what's
gonna go with 4.
You are correct. 4 ghosts. So a lot of people forget about poor Marley coming in first. So they'll focus on these 3, but this guy was here first, so he warns about these coming. In the Disney version, and I think they actually do it in the book and in the original version of the movie. Some people argue that you could say 5, because when Scrooge goes to the door of his house to go back in before Marley appears to him, the door knocker on the door actually becomes a ghost face and scares him. But a lot of people would say, no, that's Marley also that appeared. And so, yeah, I think if someone was being really picky, they could make an argument for 5 also. Good job. And again, if you're getting the holiday questions right, don't forget to send your name and address to the MSF staff after this is over, so we can put your name in the hat for the prize. All right, PML stands for progressive multifocal lymphopenia. B, primary multifocal lymphedema, C, progressive multifocal leukoencephalopathy, or D, pyloric metachromatic lipodystrophy.
Karen, can you unmute again?
C.
So we have a vote for C, and you are absolutely correct for progressive multifocal leukoencephalopathy. So PML obviously is a side effect that none of us ever wants to see with our medications. It is primarily a discussion we have with natalizumab or Tysabri, but it has been seen with some of our other MS disease modifying therapies. There have been a handful of cases with some of the B cell therapies. There have been a handful of cases with Gilenya. But generally, it's a discussion that we think about with Tysabri, and we've certainly come a long ways in our ability to sort of mitigate the risk of Tysabri by selecting appropriate people to be on it, by doing appropriate laboratory monitoring in the form of the JC virus antibody index. A lot of centers, so I would say that probably the most important take-home message if you're on Tysabri is make absolutely sure that you're getting regular JC virus antibody index testing done. The FDA recommends every 6 months. We do every 3 months here. If someone's values are starting to creep up a little bit, we may even go to monthly testing. The assay is paid for through the drug manufacturer, and we appreciate that very much from them. It makes our ability to risk mitigate a lot easier. PML is caused by A, Epstein-Barr virus, B, Jakob-Creutzfeldt, C, trickle-down economics, or D, John Cunningham virus.
Sherry, can you unmute?
John Cunningham virus.
That is correct. So the JC in JC virus, it stands for the first human who the PML was really identified in, John Cunningham. We're going to come back to some of these others in a little bit. We'll talk a little bit about Epstein-Barr virus. Jakob Creutzfeldt, if people are not familiar with that, is a really devastating neurological disease, something that we hope no one ever develops and none of us ever see. It's caused by something called a prion. It's the cousin of mad cow disease. So prions are actually little pieces of genetic material that technically are not alive, but they can take over our cells and make our cells do what they want them to do. And what that little piece of genetic material wants our cells to do is make more little pieces of that genetic material. So they take over our genetic hardware and make more little Jakob Creutzfeldt prions. So Jakob Creutzfeldt is in the family of what we call spongiform encephalopathies. They make holes in the brain. The thing that's so devastating about Jakob Creutzfeldt and other prion diseases is they're so small. They're smaller than a virus that our immune system doesn't even recognize them. So as far as your immune system is concerned, there's nothing bad going on. So these things are able to replicate, damage the brain, and are unfortunately uniformly fatal. There really is no treatment for these diseases. Fortunately, they're also very, very, very rare and not contagious. All right. According to It's a Wonderful Life, what happens every time a bell rings?
We've got Teresa with her hand up.
Teresa, what do you say?
An angel gets its wings.
So smart. Absolutely. An angel gets its wings. Yep. Also one of the best Christmas movies ever. Yep. So every time a bell rings, an angel gets its wings. Good job.
Thank you.
Move this out of the way so I can read it. Oops. So what is it called when you bend your neck and get an electric sensation in your arms or legs? Is that the A, ow it hurts syndrome, B, Lermite sign, C, Uthaugh's phenomenon, or D, Babinski sign?
Yeah, a lot of people raise their hands all at once, it seems. The first person I saw was Karen, so I'm going to ask you to unmute.
B?
B, Lermite sign. Awesome. That is absolutely correct. Good job. So Lermite was a French neurologist in the late 1800s who first described that. They obviously didn't have any MRIs or spinal taps that they could do. So a lot of the diagnosis of MS and those signs were based upon, clinical symptoms, physical findings on examination. Another important person back in that time was Dr. Uthoff. So Dr. Uthoff was an ophthalmologist who said, you know what, I think that a lot of people with MS have this funny symptom that when they get overheated, their vision dims out. So that was one of the early ways of diagnosing MS. Dr. Uthoff would take suspected individuals who he thought had MS and put them in a hot tub and see if their vision got wonky. We use that term Uthaugh's phenomenon probably a little more broadly now. So we use it really to describe any symptom that is reproduced with heat exposure, but it was originally used to describe the worsening of vision in people who had old optic neuritis from their MS. And Dr. Babinski was a famous neurologist who described the sign when we do your neurological exam. When we torture the bottom of your foot by scratching it, if your toe points upward, that's a Babinski sign. It's not specific to MS. You can certainly see it in MS. It just tells you something has bothered the central nervous system. So there's something going on in the brain or spinal cord. And then ow it hurts is just totally made up diagnosis, although I kind of like how it sounds. Yeah. What form of MS is the most common at the time of diagnosis? Would it be A, benign MS, B, relapsing remitting MS, C, primary progressive MS, or D, secondary progressive MS?
And that was Jim who raised his hand first.
Jim is on it today.
I'm on it. That would be B.
You are correct. B, relapsing remitting MS. So 85% of people start with relapsing remitting MS. So primary progressive MS is always primary progressive MS. So it is the kind of the standalone. It accounts for somewhere between 5 and 10% of people in the MS community. It doesn't play by some of the rules that we think of with relapsing remitting MS. Primary progressive MS is more common in men as opposed to women, and it tends to start a little bit later in life. With relapsing remitting MS, there's about a 3-to-1 ratio of women to men. And again, it usually starts a little earlier than primary progressive. Secondary progressive MS is what can happen to people who are diagnosed with relapsing remitting MS over years or decades. They can slowly evolve into a form of MS where there really are not relapses. There's just a slow progression of disability. Our hope by being aggressive with treatment and pushing for early diagnosis is that we can prevent that future progressive form of MS. And a Hanukkah question. Hanukkah is known as the A, alternative to Christmas, B, festival of remembrance, C, 8 nights of giving, or D, festival of lights.
And first hand I saw go up was Caitlin.
Caitlin. We got B.
No, D, Festival of Lights.
Very good. I thought you said D. That is absolutely correct. Some people might think it's the alternative to Christmas, but absolutely different religion, own traditions.
I knew that right away because my mom was born. Technically, I was born. The religion that Hanukkah is because my mom was baptized.
Okay. And I guess that, I'm not Jewish, but I don't know if Deb's still around or anyone else. So, to really the Jewish lineage is inherited through the mom's side. So that determines sort of, whether you're in the Jewish faith or not. But great holiday. I was in Israel for a research meeting, staying right outside of of old Jerusalem, right around the time of Hanukkah one year, and it was so fascinating to see all the cool thing in Jerusalem is everything that you step on, every wall you touch, everything you see is important to one of the world's major religions, whether you're Christian, Jewish, or Muslim.
Mm-hmm.
So which statement is true? A, there are no racial differences in the prevalence of MS. B, Black people are at higher risk for getting MS than other groups. C, white people are at higher risk for getting MS than other groups. Or D, Hispanic people are at higher risk for getting MS than other groups.
So Teresa had her hand up first.
Teresa, what have you got?
B.
B, Black people are at higher risk for getting MS than other groups. And that is very impressive that you got that right, because that is brand spanking new information. When we did this last year, there were studies that were in progress, but last year we would have tended to say that C was correct. And we don't, so now there are several good epidemiologic studies that are really turning the MS world on its head, showing that not only, we used to just think, okay, we know that Black people can get MS, but now it looks like they really are at higher risk than other groups. So right now, the rankings in terms of risk would be Black people, white people, Hispanic people. We don't know what this represents. Has the epidemiology truly changed? Are Black people getting MS with a higher frequency? We know that autoimmune diseases in general are going up for humans in general. We know that the sex differences with MS have shifted a little bit. There used to be about a 2 to 2.5 to 1 ratio of women to men, and now it looks like it's more 3 to 4 to 1 women to men with MS. Could it be that the epidemiology is also shifting racially? Or is it a factor of socioeconomics and cultural bias? Is it that we thought Black people didn't get MS, therefore we were not looking for MS in Black people, and so it was sort of a self-fulfilling prophecy? We don't know yet. And it may be that it's a combination of both, that the epidemiology really is changing, and that we're just doing a better job of looking at MS across all racial groups. Good job. All right. What is this boy's name?
Caitlin, I saw you.
Caitlin, what you got?
Ralphie.
Very good. That is Ralphie. All right. For extra credit, what was his brother's name?
His brother's name was it's not Georgie, it's man, I'm drawing a blank, sorry.
It's okay. An entire medical team in Nicaragua on one of our medical trips down there drew a blank for a whole week, and we had no internet access, and it drove us nuts. His name was Randy, but it drove us crazy for a week because we couldn't remember what it was. So this is a Christmas story. Also, I think this is one of the greatest Christmas movies ever. They did make a sequel that just came out within the past month. So Peter Billingsley, the actor who plays young Ralphie, is in this one, and a lot of the other actors, Flick and Schwartz and the bully are all the original actors now grown up or in the sequel. And I thought it was pretty good. If you like the first one, I would highly recommend the second one. All right. What is the best way to know if I'm not emptying my bladder completely? Could I use leakage with cough or sneeze, or an MRI of my cervical spine, a bladder scan, or waiting until I have UTIs to let me know if I'm not emptying my bladder completely?
I saw Debbie raise her hand first.
Debbie, what do you got?
I was gonna say A, but I think it's something different now.
Okay, what's your other option? It could be A. What do you?
C.
So I would go with your second guess, C. That is correct. So
Okay.
leakage with cough or sneeze could be really an indication of more of a stress incontinence. It could mean you're retaining, but an awful lot of people who just have stress incontinence, they weaken their pelvic floor, most commonly with childbirth, are going to have a little bit of leakage with cough or sneeze, and that doesn't necessarily mean you're retaining. It just means the pelvic floor is a little weaker, so may not go along with retention. An MRI of the cervical spine, I mean, if you are retaining a lot of urine, there's probably a decent chance that you've got some demyelination in the cord, but that's not really the way that we confirm it. Some people who have demyelination in the cord don't retain urine. Waiting until you have a UTI is definitely not what we want to do. We would like to catch urinary retention before you get a UTI. Having frequent UTIs could be a sign that you're retaining, but we don't want to rely on that. We'd like to be more proactive. So the easiest way to know is to get a quick bladder scan. So this is just an easy ultrasound right under your belly button. The nurse is going to have you go to the restroom, you empty your bladder completely, you come back in the exam room, they take a picture under your belly button. And the magic number that we use in MS is 100 mLs of urine. If you're below 100 mLs of urine, we're generally going to be happy with that and say you're not retaining significantly. If you're above 100, that is putting you more in the retention camp. Ideally, we'd like you to be 0, that you're close to nothing left in the bladder after you feel like you've emptied it. In people that really retain, usually it's going to be in the 200, 300 or more. We do see individuals who will swear their bladder's empty. and they've got a half a liter of urine sitting in there. The ones that drive us kind of nuts are the ones that are right at 100. So it's, it's abnormal, but it's just barely abnormal. And a lot of times in that situation where it's just a little abnormal, we may just watch it and repeat the bladder scan. So why is it bad to not empty your bladder completely? Well, it is a risk for UTIs. That urine sitting there is a great place for bacteria to grow. And as you know, if you've had UTIs, your old MS symptoms are probably going to get worse if you have a UTI. For many people with MS, their symptom of a UTI is going to be neurological, not urological. They're going to have worsened walking, worsened spasticity, worsened cognition. And so do pay attention to those worsenings. I know it drives a lot of people in the MS community crazy that when they call into, say, a call center or talk to a nurse and they're describing symptoms that could be a relapse, one of the first questions that they'll get asked is about underlying infections. And that's because we don't want to miss those. The other problem with urinary retention is that if you look here on this little cartoon of the bladder, these are the ureters that go upstream to your kidneys. If you're chronically retaining urine, that urine back pressure is going to get reflected up the ureters to the kidneys and can actually cause hydronephrosis or kidney damage over years of not emptying the bladder well. So good job.
Deb, do you have a comment? I see your hand.
Yeah, I did have a comment. The reason I'm saying this was I never had children, so I do have leakage with a cough or like a sneeze, actually a sneeze or a cough. But the UTIs I had, I'm 54 years old. I believe I went blind in the 11th when I was a junior in high school. So I had UTIs that were actually just blood and not urine, and they were very, very painful. So could that possibly be and the UTIs now, could that have possibly all those times that I had it been MS?
It's certainly possible. So, we know that by the time we diagnose a person with MS, that's not when their MS started. The MS process probably starts years before we actually make the diagnosis.
Right. I was diagnosed as a junior in high school, and I got diagnosed for real in 2017. I never knew.
Yeah, so generally, if you have a young person having a lot of UTIs, that's going to prompt a referral to a urologist, or at least it should, to say, okay, is there a neurological reason why this person's having UTIs, or they're not emptying their bladder? Is there a mechanical reason? Are they, is there an obstruction to urine outflow? So yeah, it certainly could be. I wouldn't say that, not everyone who has UTIs as a child has MS, but it's in the discussion and something that should be thought of in the differential diagnosis.
And am I not? Yeah, I'm kind of too young to just sneeze and have leakage when I never had children.
So anyone can have pelvic floor muscle weakness. So a lot of people with MS have weakness in the pelvic floor muscles. And so your MS does put you at risk for that, even in the absence of having kids.
Okay.
So a lot of women without MS will have leakage with cough or sneeze because the pelvic floor muscles are weakened from childbirth. So that there are a lot of pathways for how you can get to that pelvic floor muscle weakness and the leakage with cough or sneeze.
Okay, thank you.
Yeah, sure thing.
Dr. Thrower, I know you usually take questions at the end, but Jim has had his hand up for a while.
Jim, his arm's wearing out. Sure thing.
Yeah.
Okay.
Hey, Doc, and I'll be seeing you on Thursday, but in the name of that test, the urogenic flow test, when Dr. Sands diagnosed me with a neurogenic bladder, I retained about 400 cc's.
So if we do a bladder scan and we find that you're retaining, that's kind of the entry point into that. Gives us a clue. Okay, something's going on here. Then we're going to refer you to, if you are retaining, we're going to refer you to a urologist, and they're going to do what you just described. So that's called a urodynamic study. So now we need to really dive in and decide, okay, how is the bladder working? So with the urodynamic study, they're going to put a catheter in from below and put water into the bladder to see, okay, how much can it hold before a message goes to the spinal cord to say, okay, you got to empty at this point. And people that are retaining or have a neurogenic bladder, they hold way more urine before the bladder gets the message that it needs to empty. So like in your case where you were holding 400 mLs of urine, when normally it should be close to 0 but definitely below 100. Yeah, so that's what, you're right, that is the next kind of step in the process. Good job. In Charlie Brown Christmas, which character did not eat December snowflakes?
I saw Teresa's hand go up first.
Teresa, what you got?
Linus.
It was not Linus.
Caitlin, can you unmute?
Was it Snoopy?
It was not Snoopy.
And Debbie, can you unmute again?
I did. Can you hear me?
Yes, ma'am.
Yeah.
Was it Lucy? Lucy, the girl with the black hair. Was it Lucy? What's her name?
Yeah.
Lucy.
It was Lucy. Good job.
Yeah, yeah.
And for extra credit, why didn't she eat December snowflakes?
Oh gosh, I forgot.
Because they were too early.
She said she always waited until January to eat.
Oh.
Good job. Awesome. All right. This is from our physical therapist. A couple of years ago, I was asking them to give us a rehab question. When transferring from a manual chair to a bed, the very first step is to A, check your blind spots, B, remove your shoes, C, lock your brakes, or D, perform a few stretches.
I saw Jim's hand go up.
Lock your brakes.
Lock your brakes. Good job. Although I think you should check your blind spots. You never want to pull out in front of anybody when transferring. So yeah, absolutely. Lock your brakes so that chair doesn't go shooting backwards. When you push off to, from chair to bed, that leads to a very, I've seen people just get stuck where they're kind of their butts partly on the chair and their arms are partly on the bed and they're just kind of hanging there and usually not able to go anywhere until somebody comes and puts that chair back closer. Good job. What does HSCT stand for? Does it stand for A, highly specific cryotherapy, B, hematopoietic stem cell transplantation, C, hairy seals can't translocate, D, high-speed cell transfusions?
Karen was on it.
B as in boy, B.
B, hematopoietic stem cell transplantation, absolutely. Although I think it should be hairy seals can't transplantate. So this is an area of a lot of ongoing research. So with HSCT, you're being given a new immune system. If MS results from an immune system that's attacking things that shouldn't be attacking, what if we just gave you a new immune system? And so that's the idea with HSCT. Take immature stem cells from your bone marrow, cells that have the potential to be anything in the immune system, freeze them, save them, and now kind of clean your hard drive. Do a process called immune ablation. Chemotherapy used to wipe out the existing immune system and then give you those cells back, your own cells, through an IV transfusion and lets you reestablish a new immune system. The data looks really good in certain patient populations, and there's a very, very heavy emphasis on certain patient populations. What we've seen in the data so far globally is it looks like this works best in people under the age of 50 with an aggressive inflammatory form of MS. So a lot of relapses and or a lot of inflammation on brain MRI. The data in people over the age of 50 or in people with progressive forms of MS is not as impressive. And I think it's really important that we think about who's appropriate for this, because it's not a risk-free procedure. You're getting high-dose chemotherapy to wipe out your immune system, and there is a period of time where you are very vulnerable to any infection. You are significantly immunocompromised until that new immune system establishes itself. So there are some trials going on here in the US. One of the sites that was doing a lot of the research, Northwestern, is on hiatus. They're taking a break for right now. I would say if you're someone out there thinking about going out of the US to Mexico, or we did have a lot of people going to Russia, just do your homework, talk to a lot of people. I've had about 4 individuals go to Moscow. I would say that's probably off the table right now, just due to the war in Ukraine. Mexico is a modern facility. They are pretty indiscriminate. If you have the money, they're not going to really look at whether you're over or under 50 or have an aggressive inflammatory component. They typically will do just about anybody with the funding. So just do your homework and be a smart healthcare consumer if you're looking at this as a treatment. Which of the following is not likely associated with a higher risk of MS? Not associated with a higher risk. Would it be A, Epstein-Barr virus, B, mercury amalgam fillings, C, low vitamin D levels, D, having a parent with MS, or E, childhood obesity in girls? Which of those is not probably associated with a higher risk of MS?
That would go to Sherry.
Sherry, what you?
I'm gonna guess E.
Did you say E?
Yes.
So E, actually, there is literature out there that childhood obesity, especially in teenage girls, is associated with a higher risk of MS. So that one's a correct. Anybody else want to take a guess?
Caitlin, are you there?
Yes. So I was thinking that it would be B.
You are correct. Mercury amalgam fillings. So there was a lot of interest in this years ago, and there were actually dentists out there taking mercury amalgam fillings out. And it's one of these situations where a little bit of truth then translated into something bigger than it should have been. Mercury is neurotoxic, but there's no evidence that the mercury in fillings is associated with a higher risk of MS. Dentists are not using mercury amalgam fillings. They're using different things now. If you have mercury amalgam fillings, your dentist is probably going to talk about taking them out, not really for safety reasons, but just because they degrade over time and they're at risk for breaking and falling out. So they're probably slowly being phased out anyway. But again, someone took the thought that mercury was toxic at high levels and then made a jump to a conclusion in MS. Epstein-Barr virus is most definitely associated with a higher risk of MS, and there were 2 big studies this year. One from the military that looked at over 10 million young military members, and when they had Epstein-Barr virus and when they developed MS. So almost all humans have been exposed to Epstein-Barr virus. If we do antibody testing for Epstein-Barr virus, and anyone listening to this, chances are very high that you've got antibodies to Epstein-Barr virus. It's the timing issue. It's the degree of infection you get with Epstein-Barr virus, and when you got it, and do you carry the right genetics to react to it in a way that would send you down the MS pathway. The researchers at Stanford this year made a large leap forward in our understanding of how Epstein-Barr virus interacts with the human immune system and can potentially contribute to MS. They identified the receptors on the surface of Epstein-Barr virus that are potentially generating an abnormal immune response, the antibody that's being produced, and the protein in the central nervous system that's being attacked. That's a really big deal. That could lead to treatments, now that we understand that piece of it. There's a lot of research on Epstein-Barr virus vaccines. If we could vaccinate against Epstein-Barr virus, we would, in theory, drastically lower the risk of MS across the world and also lower the risk of certain cancers which are associated with Epstein-Barr virus. Low vitamin D levels have definitely been associated with a higher risk of MS. We do check vitamin D levels in everyone with MS. We would like for your levels to be somewhere in the 50 to 80 range. There is no perfect dose of vitamin D. The perfect dose of vitamin D is whatever it takes to get you into that 50 to 80 range. Having a parent with MS or having any first-degree relative, parent, brother, sister, child with MS does carry a higher risk for MS for those first-degree relatives. So if your mom or dad has MS, you've got about a 2.5 to 3% chance of having MS in your lifetime, and that is higher than the general public. And then we mentioned that it's not a huge risk factor, but childhood obesity has been associated with a higher risk of MS. Good job. Which drug is not used to treat MS bladder symptoms? Would that be A, tizanidine, B, oxybutynin or ditropan, C, DDAVP, D, tolterodine or detrol, or E, mirabegron or Myrbetriq? Which of those is not usually a bladder medication?
Caitlin's got it.
Hey, tizanidine.
You guys are just too darn smart. Man, you've not missed
Take
anything.
It's not a bladder pill. Can I say what it is?
Yeah.
Tizanidine is known for psych meds.
No, tizanidine. There's some drugs that sound close to that. So tizanidine is an
No, it's migraine med. Sorry.
Nope, not migraine.
Seizures?
Spasticity. So spasms and spasticity. So the two most commonly used medicines for spasms and spasticity in MS are going to be either baclofen, which has been around forever, or tizanidine. You can't say one's better than the other. They're just different. They have different mechanisms of action. We can, in theory, use tizanidine with baclofen to treat more severe spasms and spasticity. We always get grief from the pharmacist when we do that. They'll say, well, this person's on two different spasticity drugs. We'll say, we know they have two different mechanisms of action, and we've tried one and it didn't work. We tried the other one, it didn't work. So we're going to try both of them together. So oxybutynin and tolterodine are what we call anticholinergic drugs. They help an overactive bladder relax and fill up a little bit more. Because of that mechanism of action of working on acetylcholine receptors, we have to watch out for dry mouth and constipation. If you have dry mouth and constipation with one of these types of medicines, that's when we go to this type of medicine. So Myrbetriq is not an anticholinergic drug. It has a different mechanism of action, doesn't tend to cause dry mouth and constipation. In a perfect world, we might be tempted to go with this first. Insurance companies don't live in a perfect world. They're going to want us to try one of these first because these are cheaper, but just know they're two different classes of drugs. DDAVP is a medicine we use to treat bladder symptoms, but it doesn't actually work on the bladder. It works at the kidneys and tells your kidneys to back off on urine production for a little while. So if you're getting up a lot through the night to empty your bladder and it's interrupting your sleep and you're tired in the daytime, we might look at this just to get you through the night without having to get up as frequently. All right. I think we're coming close to the end here. Another holiday question. Urban legend has it that this company invented Santa Claus. Which company is rumored to have actually invented Santa Claus? Not true, but urban legend says so.
So that would be JW.
JW, what you got?
I was just going to guess Coca-Cola.
And you would guess absolutely correct. So I had to put this in here. I'm in Atlanta, so home of Coca-Cola. So Coca-Cola did some great marketing and used, a lot of these classic Santa pictures. So there was this rumor that went around that they had actually invented Santa. So Saint Nicholas was a real person in Turkey in the Middle Ages. He's actually a Catholic saint. He is the patron saint of mariners or sailors. Don't know how sailing and Santa got together, but he was very much a real person. Good job. And we got a couple more here. About how many people in the United States have multiple sclerosis? Is it A, 1 billion, B, 1 million, C, 400,000, D, none? MS is fake news created by the Russians.
About,
Caitlin.
sorry,
Caitlin, what do you got?
about 1 million, B.
You guys are too smart. That is absolutely correct. So a few years ago, the National MS Society did an updated study and showed that at least 1 million, it's probably more than that, of people had MS. We used this number forever and ever. When I started neurology residency in the 1980s, we were saying 400,000. When I finished training in the 1990s, we were using 400,000. When I started here at Shepherd for 21 years ago, we were using 400,000. So we knew that was wrong. There just had been no updated study. So yeah, 1 million people in the US. MS is the leading cause of non-traumatic disability in young Americans. So Shepherd Center is an interesting place. So I work only in MS, but Shepherd also works with spinal cord injury and brain injury. So across the spectrum of MS, brain injury, and spinal cord injury, we're really working with all of the common causes of disability in young Americans. Good job. I think this one may be the last one. All right, what real-life department store is featured in this movie, A Miracle on 34th Street?
Caitlin again.
Caitlin,
Macy's.
too smart. Macy's is it. Good job. Awesome. I think that may have been the last one. Let's see. It was. And just, I wanted to finish up by thanking the amazing MS Focus staff. You guys have, I've worked with you for years and years, and as always, you do a great job. On behalf of MS healthcare providers, the MS community, we appreciate everything you do and all of your hard work. All of our sponsors in the pharmaceutical world, we couldn't do this without your sponsorship. And then for all of you attending, your members of the MS community, support partners, our hats off to you. We see you fighting the fight every day. We know some of you have obvious physical disabilities. Some of you have disabilities that we can't see, obviously, and we our hats are off to all of you. We know you're brave warriors, and we will continue to fight alongside you. And hopefully, we will all have a cure one day when we can stop MS before it starts. We can reverse the symptoms that people are already dealing with, reverse any disability, and we can all sit on a beach under an umbrella and have a pina colada together. I don't know how are we doing on time here?
We are. It's 5:35 Eastern.
So
Do you have time for questions?
So I probably have time for maybe 2 questions.
Okay, so I'm going to go with the ones that I saw first. Jen asks, how do you know for sure if you have primary or relapsing remitting MS? She says that she had one attack with recovery except for sensory symptoms. She says if you don't have another attack, say within 5 years, is it likely that it will be primary progressive?
So not necessarily, and we appreciate that it's not always easy to know which label to use on someone, but technically if you've had a relapse and we don't have a better explanation for it, so we're comfortable that attack was MS related, you are in the relapsing remitting camp. So primary progressive MS is primary progressive MS from day one. And a common story with primary progressive MS would be walking issues that just kind of slowly creep up on someone. So I take a jog every day, and now I start noticing maybe at a half a mile that my right foot is dragging a little bit. And next year it's my left foot that's jumping in on the action. And now it's at a quarter of a mile. And now as time goes on, it's even with just a brief walk that I'm getting weakness in my legs, and then you just have that progression of gait issues. primary progressive MS tends to be more of a spinal cord than a brain issue. Not always, but typically. So it tends to be more of a walking issue than an optic neuritis or, a sensory attack sort of issue.
And the next question comes from Margie. She says, does collagen peptides help with cognition?
I would say jury is out. There are a lot of things. I mean, technically, we don't have anything that is FDA approved that has been absolutely shown to improve cognition. There are, some supplements that you see. You hear a lot of ads for Prevagen out there. I'm certainly fine with people trying these things out. I think we have heard individuals sometimes say, yeah, I think it helped a little bit. When we think about cognition, your other resources, realize that speech language pathologists do cognitive rehabilitation. I'm a big fan of that for helping people come up with strategies to function better. Neuropsychologists can help you document and really quantitate what's going on cognitively, especially if you have a vocational issue. You're thinking about changing jobs, modifying jobs, leaving the workforce. And you're doing it because of cognition. I would really encourage you to get a good baseline neuropsych eval so you know exactly what works. And then if you are applying for disability, you've got some ammunition to objectively document what's going on with you. There is some limited data for some of the FDA approved therapies for Alzheimer's, like the drug Aricept, helping a little bit with cognition. So we will sometimes pull those out of the hat. Realize when someone has cognitive issues that if they also have any mood issues like depression or any fatigue issues, that depression and fatigue will make your cognition look much worse. So sometimes we treat your cognitive issues by treating the fatigue and mood issues because we know that'll make your cognition look better.
So for those of you who have your hands raised or have typed questions into the Q&A, please respond to the confirmation email for this conference with your question, and then we can send them to Dr. Thrower and he can get back to you with an answer. Unfortunately, that's all the time we have for today, but if you missed any part of the conference, please head over to our Facebook page where you can watch the live stream recording once this presentation ends here in the Zoom. Please follow us on Facebook, Twitter, and Instagram for times and access information. And our next conference will be this Thursday, the 8th at 6:30 p.m. Eastern Time with Dr. Fred Foley, who will be discussing enhancing sexual wellness. This was fun as always, and we thank you guys for participating. Glad to do this with you again, Dr. Thrower. Hope everybody has a happy holiday season, and we'll see you next year.